After graduating from the University of Maryland School of Medicine, Dr. Burval completed family medicine residency at the Ohio State University Wexner Medical Center. She completed her faculty development and global health fellowship at UPMC's St. Margaret and earned her MPH from the University of Pittsburgh School of Public Health. Now core faculty with Forbes Family Medicine and Monroeville, PA, Dr. Burval provides inpatient and outpatient care and enjoys working with learners of all levels. She is especially passionate about global health and the history and philosophy of medicine. So with that, Dr. Burval, go ahead and take it away.
All right, everybody. Hopefully you can hear me clearly. If not, wave wildly and we'll figure it out. But I am really excited to be able to be here with you all. It has been a long time in coming. I think your group invited us to come and give this presentation 2 STFMs ago. And so we finally made it happen, which I'm very excited about. But my name is MaryBrooke Burval, and like Amanda said, I am faculty at Forbes Family Medicine, which is just outside of Pittsburgh, Pennsylvania. And I want to be clear that this presentation, even though I am the one presenting it today in my current role, the work that was done to create this presentation was a collaboration of several people who completed the Faculty Development Fellowship at UPMC St. Margaret's with me. This was the team of folks who worked on this presentation, and I just want to make sure that they all get credit because it was definitely a collaborative effort. And I am just the one who was available to be able to present it with you all today. I have no disclosures to make to you all today. I'm just excited to get to be here. I have no conflicts of interest either. And as you might have gathered from the name of this presentation, we're going to be speaking about death and dying. And I want to just really encourage everybody that it's fine to have a lot of emotions when talking about that. Death and dying can be tricky topics, and there can be many things that are provoked or maybe uncovered. I really hope that this can be a safe space for all of us as we're working together and tackling a topic that can be tough. And I also want to say that it is absolutely fine if you need to take a moment to maybe step away or put your camera screen back on, don't show my face while I get a little bit of composure back kind of thing. That is absolutely fine. And then the last thing that I do just want to emphasize is that everybody's experience with death and dying is different, depending on your family of origin, your cultural background, your religious situation. People have all sorts of different experiences and conceptualizations of death. We're not here to have any conversation that is comparing one or saying one conceptualization is better or just different, basically, and that how can we use our different ideas of death when we're working in a field in healthcare that we encounter patient deaths. So I have another slightly more lighthearted content warning, and this one is just that participation is going to be necessary from folks for the session. And I understand it's lunchtime, so if you need to be able to eat your salad and talk with us, we hope that that you'll still be able to do that because it will be, I think, a lot more robust experience if we are able to participate and work together. So I'll thank you in advance for that. The objectives, the things that I'd like to go through today, number one, just describing a little bit the impact of patient deaths on providers, and this is going to be a combination of personal experiences and maybe experiences from others that we'll talk about. Then our second objective is to apply the patient death debriefing session model. And then the third thing that we're going to do, and this is the big participation moment, is practice debriefing using the patient death debriefing session model. So in order to kind of get us thinking and in the space and the mindset to be able to think about this, what I'm actually going to ask everybody to do is just take 2 minutes to either type or maybe jot down or send yourself a text message or just reflect on a patient death that occurred early in your training or in your career. And if there are folks who don't have clinical experience dealing with patient death, just think about maybe a death that you experienced in your personal life, maybe that of a family member or a loved one. And what I'd ask everybody to do is to just maybe jot down a few of the specific things that you remember about that experience, whether it is, something that you sensed in the moment, whether it was a sound that you heard, a scent that went alongside with the experience, or maybe emotions that you felt in the moment, or emotions that you maybe felt afterwards. So I'm going to set a timer for 2 minutes, and then we will share this, hopefully using a word cloud activity as a group. About 15 more seconds. All right, so what I hope now is that y'all can see the QR code. Or if a text message is easier, go ahead and see if you can share one word, or maybe a couple of words about that experience, and kind of what were the things that you remembered or reflected on. So just looking at this word cloud, there's a lot of different things that people have. We have some positive, or words with more of a positive kind of connotation, things like loved, things like relief, maybe quiet and hugs. And then some other words that don't have such positive feelings, things like helplessness or guilt or maybe suffering. So as we can see, even just from this short exercise, the reactions and the experiences and the things that we remember about deaths are run a gamut, from suffering to love. And that is so true and so human. So thank you all for participating in that. I appreciate your thoughts, and hopefully that'll be a little warm up for kind of some more participation to do as we go on. So death is something that will find all of us in our careers or in our personal lives. And it can be really hard to handle, and really hard to know sort of what to do. I remember the experience that I was reflecting on in that same two-minute period was one of the first patients that I ever did CPR on as a resident. I was in my intern year. And this was a woman on the surgical service. I was rotating with the general surgery service at that time. She had colon cancer and was she wanted to have the mass removed. She was an older woman. She was probably 75 or 80, and she was not in very good health. But the surgical team, we felt that, it was reasonable enough to offer her a surgery to remove part of the tumor, hopefully all of it, at least make her a little bit more comfortable in terms of how her bodily functions were going, and then potentially follow up with some other treatment after surgery. But she didn't do well. Following surgery, her kidneys started to fail, her heart was having issues, she had a whole bunch of fluid retention. It really did not go well for her. And I remember coming in before rounds one morning, and we heard, the code blue called overhead, and that was our patient. And so I and my senior resident were going down to the surgical ICU to be able to see what we could do in the situation for this patient. And my senior resident was very intentional. I mean, she was a great leader in a lot of ways. And she said, "MaryBrooke, I want you to make sure that you get to be, involved in doing chest compressions. If that's what we're doing, we want to make sure that you have that experience." And I will tell you, I will never forget that experience of CPR for that patient in that code. It was, it was a lot. Her ribs were already broken. There was stool coming out of her mouth because she had been so obstructed. It was everything that is like, wow, this is really hard about CPR and coding somebody. And I like those memories will be with me forever. And while I really appreciate my senior resident, wanting to make sure that I was involved in that experience and that I had that opportunity to care for my patient in that way, in that moment with CPR. Afterwards, there was very little sort of debriefing or very little follow-up. And I felt like she was so intentional on the front end, and then on the back end, I was just kind of left on my own. And that probably, unfortunately, is not a story that is unfamiliar to some of you. Hopefully few of you are familiar with stories like that, but we all probably have something similar that we've dealt with where you're just kind of left reeling after a situation, and you don't know what to do or how to move forward or what to even think or feel in some ways. So talking through then, when we're trying to do a good job for the learners under our care, so that when they're dealing with patient deaths, that they don't have an experience quite as jarring as mine, or at least has maybe a little bit of a better follow-up and debriefing, we want to talk about now for the rest of the session, like what are interventions that can help learners deal with death. And there is no standard, unfortunately, but both the ACGME and the American Academy of Family Physicians, everybody recommends that residency programs, they include core curricula and end-of-life topics, that this is a topic that's addressed, that palliative care is included. And so, we expect our learners, our residents, and our students to experience end of life. But what is the standard for helping them deal with those experiences, and what are the things that can help with that? So there are some interventions that have been, at least anecdotally, if not necessarily studied in a randomized control trial to quite the full extent that it could be, because this is one of those, this is not a hard science topic in the same way that some other things that we deal with in medicine are, but some interventions that have some evidence to help with learners processing our communication workshops. So first of all, just making sure that people know how to use language about death, how to use euphemisms appropriately when it's not appropriate to use euphemisms. If there's a particular cultural context where language and communication matters a lot when talking about death, making sure that learners have access to that information. Didactic sessions, again, similarly, teaching and education to make sure that people feel at least a little bit more comfortable with talking about death and understanding what it's going to be. Palliative care rotations are another way that residents and students can get exposure to end-of-life conversations, to end-of-life scenarios, and process through what it means to die, as well as the implementation of something like death rounds, maybe a resident-led monthly experience where you talk about and you remember the people who maybe died, who were part of your practice or part of your service that month. And then the last thing, and the thing that we're focusing on today, is real-time supportive discussions, debriefing, and teachable moments. So from the debriefing standpoint, first, I just want to make sure that we set set us all on the same page about what is debriefing. Merriam-Webster gives a definition that I think is one that we all probably are a little bit familiar with. Debriefing, it's careful review upon completion. So we debrief all sorts of things. We can debrief patient deaths. We can debrief some of those near misses. We can debrief after a, sort of incident or something in the clinic or office space. It's just that careful review of something once it's done. And there's no universal way to debrief patient deaths with learners. There are all sorts of methods and all sorts of suggestions and ways that people do or in their own personal practice have found is helpful. But I want to introduce you all today to a model from Jennifer Eng and colleagues who are at Sloan Kettering. And we're using this information with her permission that I'm sharing with you today. But they did some work back in about 2015 about debriefing and working with residents. They did a study of structured, brief, real-time, consistent attending-led debriefs with the learners on their hospital. There was no attending training that was required, so attendings were just able to lead these sessions without any sort of formal preparation ahead of time. And then learner responses were gauged using a pre-rotation and post-rotation kind of survey and assessment of differences. Their work was used questionnaires, and residents overall found the sessions helpful and educational. They appreciated the physician leadership of the debriefing sessions, that they felt that their team leader was the person who was kind of leading the session, and that people who they associated positively the number of sessions with the amount of support that they felt like they received. So more debriefing sessions throughout a rotation meant that the learners felt, in general, more supported throughout the rotation. And this debriefing model, the patient death debriefing sessions, it is a straightforward model developed by Jennifer Eng and her colleagues, and I'm going to share it with you all now. So we'll go through this in a little bit of detail, and then we're going to do some practice with it. So the first part of it is just reviewing the goal. And the goal is just to focus on the emotional reactions of house staff after patient death. And this is not to find solutions. This is not to tell somebody what to feel. It's just to focus on the emotions and let the emotions have room to breathe. And so the structure of these sessions, it's a 10-minute debriefing session held by the person leading the service, typically the attending, preferably within about 24 to 48 hours of the patient's death. The ideal goal would be maybe 2 to 4 sessions per month during a rotation. And if there are no deaths, maybe have the team debrief about patients that are perhaps at end of life, or perhaps didn't necessarily pass away while in the care of that team, but maybe passed away or died at a different point in time, maybe later in their hospital course if they were transferred or something like that. This little pocket card that Jennifer Eng and her colleagues developed did include as well some additional resources just about her institution's employee assistance program, phone numbers to be able to reach out to if somebody needed more support. And so there were 5 questions that were a part of the debriefing session. And the first question is, how does this patient's death compare to your prior experiences with patient's death? The second question is, was this death unexpected or expected? Did you feel prepared for this patient's death? How could you or the team have been better prepared for the patient's death? How does the patient's death emotionally impact you? And then the 5th and final question is, how do you deal with death and dying? You'll notice that these are primarily open-ended questions, and the few that are not so much tend to have a little bit of follow-up. This is not really a yes or no debrief. It's really just, again, trying to give people space to process and to let their emotions be felt. So what I would like to do with our group is a little bit of practice debriefing. And I see that we have 1, 2, 3, 4, about 6 of us. So I think we'll just do it as one group if that's okay with people and they're willing to participate as a group of about 6 or 7, including myself. And what I'm gonna share with you all, hopefully now in the chat, is the pocket card so that you all can have it. Or I can just flip back to that slide, and maybe if you have your phone handy, you can take a picture of the questions. What sounds easier? I'll see if I can send it in the chat. Let me stop sharing for one moment and then send that to you all, and then I will be right back on my screen share.
Dr. Burval, I think that'd be fine if you are able to just post it in the chat and we can refer back to it. Yeah.
Perfect.
And I did just want to note, I see a few people have joined since the beginning. We are recording this session, so if there is anything you want to speak to, sensitive wise, we can ask for this to be scrubbed or before it's posted online. Just a side note.
Thank you for that. And so I have sent the questions in the chat. And now I'm gonna go back to sharing my screen with you all. And what I'm actually going to share this time is the patient case. So we'll go through that. And then we're gonna do some practice. So share my screen. So hopefully you can see now the patient case, which I'll read to you all. So you are part of a multi-level interdisciplinary team. This team is a teaching service, so it's made up of the attending. There's some medical residents, some pharmacists, and some medical students. This team has been taking care of a patient named Jane. Jane was a 78-year-old woman with diabetes, with heart failure, with kidney disease and COPD. She was brought to the hospital with sepsis due to an infected, non-healing leg wound that ended up requiring pressor support. She was being cared for in the ICU by your team and unfortunately passed away overnight. So your team comes in the morning and you find out that Jane has passed away. She was somebody who was overall quite well known to the team. She was frequently treated at your hospital for heart failure exacerbations. She'd definitely had more than one admission in the past few months. She was consistently seen in outpatient clinics for her diabetes management, and the pharmacy group worked with her a lot there, trying to get her better control of her blood glucose. And she was just very friendly. She was always very kind to all of the staff, all of the learners, and she's going to definitely be missed. So the roles that I would like people to hopefully participate with are the attending. And so I'll again, we'll go through these real quickly and then we'll assign roles hopefully and do some practice. So this is the attending. You're in charge of leading rounds. You've rounded on several patients so far. You notice that one of your third-year students is really not paying attention as much as they usually do. This is not typical for this individual, so you want to take a moment to speak with them privately. before they present their next patient, and they tell you that they're feeling a little overwhelmed, that they hadn't realized, like, wow, how precious life can be and how quickly it can all end. This is their first ICU rotation, and they've never experienced the death of a patient that they've cared for so closely. They want to know how they can better cope. Does anybody want to volunteer for the role of the attending?
I can do that.
Okay, I heard Miss Ortega, so we'll give you the role of attending first. Thank you. So the next person, if you'd like to be a pharmacist, if you're not one in real life, this is a pharmacy resident. This person has been rotating with the service for 3 weeks, and so far not very many people have passed away. You were one of the pharmacists who was working with Jane in the outpatient clinic to try to manage her insulin and her glucose monitor. She was really lovely and one of your favorite patients. You have seen patients die before, but this is somebody that you've been caring for quite some time, and so it was really shocking to you, and you're especially feeling a little rough because you keep thinking how it might have been different if her blood sugar control had been better. So does anybody want to be a pharmacy resident for this scenario? Perhaps a medical intern or a medical student sounds a little more appealing to someone. Does anybody want to volunteer for either of those, and then we can go through them?
I can volunteer for one. I'm neither of those things, but I can try
Would you like
that
to be our
perspective.
pharmacist, Amanda?
Sure, yeah.
All right, thank you.
I mean, I'll jump in. I'm not sure what to do, but whatever is asked of me, I guess.
Thank you so much. So this is why we have roles, and we'll give you a little of info. So if you want to be our medical intern, you are somebody who has been rotating on the service for 3 weeks. You were Jane's outpatient primary care doctor and helping take care of her chronic conditions. Again, this is somebody you've taken care of for a long time, and so it's a little bit shocking to you that to lose somebody that you've known for several months, and you're having just a hard time coping with it. She's somebody that you've known since you started residency, and you're going to really miss her. So if anybody else just wants to, still participate and maybe take on the role of the medical student or something like that, that would be excellent. But what we're going to have next is just, we're all going to, I will be a medical student in this scenario. And we're going to ask that our attending, Dr. Ortega, lead us through the questions for this. So hopefully, Dr. Ortega, you're the main one who needs the questions. I'm gonna switch my screen on back, and we will kind of go through this. And again, this is nothing, nothing that is, there's no right, there's no wrong. There's just kind of, what do you think, what do you imagine might be the reaction of somebody in that role, and let's talk through the questions. Does everybody feel okay participating in this? All right, we've got a thumbs up from Amanda. So attending Dr. Ortega, are you able to lead us?
Yes, well, good morning, everyone. Yeah, I know that Mrs. Jones passed away last night, and that was really, or Jane rather, passed away last night, and that was really difficult for a lot of us. And so I just wanted to spend a little time just doing some debriefing around that so that everybody can talk about it and just talk about their feelings around her death. So I'm just going to lead with some questions, and I just love to hear from those of you who are comfortable speaking. So kind of thinking about what happened with Jane, how does this affect you, or how does this compare to your prior experience with the patient's death?
Well, I'll go first. I'm the third year medical student, and I can just say I've never I've never really had anything like this before at all. I just, I started my third year rotations a couple months ago, and they've mostly been like outpatient stuff. And I know our ICU rotation, definitely there's lots of sick people, but I don't think I've had anybody like that I've cared for this much, like, die. And so that I just like don't even really know what to think, quite frankly. I'm feeling a little overwhelmed.
Yeah, and I mean that is completely understandable. Some of us who've been doing this longer, we've seen these things before, and I think we can all remember losing that first patient and how that felt. And so that's why we're doing this. So we'll talk about it more, and I just want you to feel free to continue to share as we go through this process.
Thank you.
Does anyone else have anything to say about the first question?
I'll just say that I'm very saddened by this. She was my patient for 2 years, and although I knew she was in bad health and deteriorating, it's still very sad. It's sad for her family.
Yeah, and as her PCP, you had a very special relationship, and so it's this is it tells me that you actually do truly care for your patients, and you have the strong relationships, and so it's really very normal and good that you're feeling this way, even if it's uncomfortable. So I just wanted to tell you that. Um, Anybody else have anything to chime in here? Um,
Dr. Ortega, we can't hear you anymore.
okay. Well, I was trying to get back to the chat, so now I found it. Okay, so back in character here. So just from your perspective, was this patient's death expected or unexpected?
As the pharmacy resident, I knew her in the outpatient clinic. So having her pass in inpatient was kind of unexpected, I think. So I'm just having a hard time coping with it and maybe feel a little guilty. Maybe I could have done something to help her with her medicines and anything else that I could have helped her with.
Okay. Yeah, and I think it's really normal when you go through something like this to go back and question some of your care decisions. Again, I think that's a good thing to go through when you lose a patient. Um, but ultimately, sometimes we do everything and these things to happen. And so, again, if you can take any learning from it, wonderful. But at the end of the day, I do believe as a team, we were providing really good care. And unfortunately, we just weren't able to stop the process for our patient that was happening.
I think for me, Dr. Ortega, what was really like, I guess, unexpected about this, because I remember when I was like chart checking for her when she was first admitted, because like they let me help do the admission for her, but just like she's been here so many times. Like she was here a month ago, she was here 2 weeks before that. Like she's been out of the hospital probably like 8 or 10 times in the past year, if I remember correctly. And so I guess I just am like, what's different this time? Or like why this time as opposed to the time before? And so I guess in my head, I was just kind of thinking like she would just get better again because she always seems to get better and go home. So yeah,
Right.
I am kind of surprised. This feels unexpected.
Okay. Okay. Yeah. And, I wasn't always the attending when she was here. It's one of those things that we see in medicine, unfortunately, when people's in their last months and years of life, they often have multiple admissions. And so their bodies get pretty worn down just from the processes that are bringing them in so often. So it's nothing that we ever want to take for granted or just assume is going to happen. But we do see it, unfortunately, as people are nearing the end of life. It's really common for them to have multiple admissions. And then you never do know when they're going to get better. Sometimes they'll rally, and sometimes, like in this situation, things didn't turn out that way. But I can definitely understand, how that feels as a medical student on your first rotation. Any other thoughts about that? So, did you feel prepared? It sounds like for most of you, you weren't really thinking that this was going to happen with this admission. But did you feel prepared just for the idea that somebody could pass away on our service? And if not, how do you think you could have better prepared for this patient or any other patient on our service?
I have to say I was not totally prepared for this patient's death. Like I said, I saw her deteriorating, and I know that self-care has a lot to do with the outcome of the situation. That's why she would get better when she would come here, because we would do our best to care for her, give her the best care possible, and then she would deteriorate because of the self-care she was giving herself. And although I wasn't prepared for this sudden death, like I said, I did see her deteriorating.
Mm-hmm. Okay. What about the rest of you?
I mean, I knew she was sick. Like, obviously she's in the ICU, but I guess I've seen a lot of people get better from the ICU. And so I think I was just kind of hoping that that would happen for her too.
Mm-hmm. Absolutely.
Yeah, she was one of my favorite patients, so I was hoping she would just improve.
Okay. Yeah, so kind of thinking ahead, because unfortunately this won't be the last experience that you'll have with death throughout your career. What are some things you can do to just mentally prepare for these situations? Is there anything you can think of?
I think, Dr. Ortega, something that you said a little bit earlier is probably something really good to remember, I think you said something about how, like, a lot of people, as they get towards the end of their life, like, they're in and out of the hospital a lot, and that their body just, like, wears down. And so I think probably it would be good for me as I, like, move on to my next rotations and, like, next year of medical school and stuff to just kind of remember that. And, like, there's only, the body is really amazing. I've definitely learned that in medical school so far, but it can only handle so much. And that after a point, it does just kind of wear out. And so maybe keeping that a little bit closer to the front of my mind going forward.
Mhm. Absolutely. It doesn't change how you take care of people, because obviously our goal is always to help them get better. But you do have to just kind of know that at the same time, right? So if we're seeing that pattern happening, it's kind of an indication, that this person may just be wearing down. And it's a good reminder, to even have conversations with them about that, and with, what their thoughts are about their mortality, and, just process that with them if we're able to. I think that's also very powerful.
I think as the pharmacy resident, being able to like integrate better with the rest of the care team, getting like a more up-to-date and realistic view of her specific case might be better to kind of anticipate what might happen a little better.
Okay, so maybe we weren't really talking very much about her prognosis um, in a realistic way, perhaps, or in a way that everybody understood or was on the same page about. Okay.
Dr. Ortega, I'm going to stop you at this point.
Okay.
Thank you so much for really quite skillfully leading us in that conversation. Everybody else, you're welcome to come back to your normal self and out of your character. And we're gonna take a couple minutes to actually debrief the debrief. And so hopefully you can see my next slide now that says how did that make you all feel? Like what was your experience with that debrief and playing the role of someone who's just lost a patient?
I like that activity. I think the feedback that we got in the roles was pretty useful. You can tell. I think everyone has been touched by this topic, and just increasing the awareness and like talking about it, I think is a good step that everyone can relate to.
Yeah. So just like the idea that death touches us all, clinical, non-clinical, everybody has the experience the death of somebody, and so being able to open up and talk about that a little bit and reflect on that can be a really good thing. I personally will share that I felt very comforted by my attending, Dr. Ortega. I felt like she shared things that were, I could tell that she has experience and that she was empathetic to kind of the feelings that I was going through as a student. And I think I felt reassured to know that, like, oh, it's okay to feel like overwhelmed in this moment. That's normal.
Mm-hmm. And definitely, I mean, I had some not great experiences handling these things. I mean, if it's okay, can I tell a quick story? It was when I was an intern. We got to spend a month doing a lot of different things to kind of give us a break. And one of the things we did was go out on a helicopter with the trauma team. And so I was kind of excited about it. I thought that's kind of cool. And the first thing we went to was an MBA, and they were putting a woman in the ambulance, and really didn't know anything more. Just saw this in process. It was very shocking and jarring. And she didn't make it, and so the lead nurse or whoever he was, he got her ID, and he looked at it, and she was 17. So it still makes me cry thinking about it. And it was just really shocking because I watched her die. And I'm thinking she was on her way to a football game probably, and her mom doesn't even know. And how awful that's going to be to have to tell her mom. And so I'm just trying to process all of this. And the nurse, he just goes around the corner, dumps his chest twice, and then that was it. And it's almost like we didn't talk about it. He just told me, like, well, this is just what we see, kind of, and you got to get used to it, and you got to toughen up. Was sort of the message I got, because I was devastated. And so I definitely, and then I think as residency went on, they did become really common, right? You lost patients and you got a little numb to it. And on my last call, I just remember coding a guy in the ICU. It was, he'd been there for a burn. And, I wasn't even really thinking about it. He wasn't my patient. We just had to respond to the code. And he'd been coding all night. And finally, we just called it because it wasn't like, it was not helpful. And so I remember walking back to the resident room, and I passed by and I saw his family. And it was like, oh my gosh, like this was somebody that was loved, and I mean, I think for me, it was just a job that night. And so I went and I just started reading his chart, and it was just like, I just sat there and cried by myself. There was really nobody to go through these things with, right? Just reminding myself to be human and remember there were people involved. And so, yeah, I mean, those things stick with you for sure. And I'm glad that you're talking about this and that we do tell learners it is okay to feel. That's what I tell them all the time. Like, don't shut down those emotions, because that's when you'll stop being a good doctor, if you don't let yourself feel. And it's okay to be sad about your patients passing away.
Thank you so much for sharing that. Yeah, like it's just so hard because I think our training, and even when you think about something like CPR, there's an algorithm, there's steps that we're supposed to follow. And in some ways it makes it easier because, okay, now it's time to push the epi, now it's time to give the bicarb, now it's time to do a pulse. Like the algorithm, it's meant to help us, be better and be more effective in like a code situation. But at the same time, well, the disconnect from the humanity of a patient, of a person, if the only view that you have of the code situation is I just got to get through the algorithm. And it's a really hard balance of being able to feel things. But like that EMT or the nurse with the helicopter, like the night wasn't done, I'm sure, after that accident. And how can we hold both of these truths in our hands at the same time, that our job calls us to keep going, but our humanity needs us to take a minute, at least a minute, to sit and be and feel and be a human. That's really a very hard thing to teach. And I think it's something that we need to be able to model, I think, because talking about it without showing it doesn't necessarily work in the same way, or what you see other people do is maybe what you learn that you think you should do too, for better or for worse in some ways.
Right.
Yeah. But thank you so much.
Just something ache out of your chest, right? And you'll be fine.
Yeah. Was there anything that people really disliked or liked about the process of talking through those questions?
I definitely like the way Dr. Ortega handled the questions. She did very well.
Yeah, felt really supported.
You can give me feedback too.
Felt really supported.
Okay.
I personally really like that that these questions don't feel like there's a wrong answer. And that you can just kind of talk about it. And I really every time I've like done this or presented this information or debriefed with people in real life, like the conversations are very different. And I think it's a really I learn something every time. And so I like that the questions allow that kind of space.
I think the questions being open-ended is like amazing, because even if you don't answer all the questions, it just opens up the discussion for other things, which I think is, one of the main points here is just to open up and talk about it.
Yeah, absolutely. I think it's intentionally set up to be just a kind of an opening conversation. Because it's something we should keep talking about, and it's okay to keep working through. Was there anything about the process that maybe even just like playing your role, like you felt uncomfortable, or anything that you would do differently or say differently in a different scenario now having gone through this one?
Honestly, I felt like it was a little awkward. I wasn't sure exactly what I was supposed to say or do. Although maybe in real life though, I would like to have maybe just more questions like about my personal feelings about it, maybe like dig a little deeper.
Okay, so maybe the opportunity to share maybe more personal experiences or kind of more personal connections,
Right.
Rather than necessarily focusing maybe a little more on like what clinically happened. Okay. I think that, totally valid. And sometimes talking more about personal feelings is a really important part of being and getting to process through these things. I always have.
And I think
Go ahead.
I was going to say we just didn't get to the question about how did this affect you personally. So we just ran out of time, but I think that would have been a good opportunity to have that piece of the conversation.
Yeah, and yes, and thank you for pointing that out. I'm trying to be mindful of our time so we got to get to this discussion too. But yes, there is a final question or a fifth question that opens up for just like, how does this feel to you? And I think one of the things about these questions is you don't have to use them in any particular order. Yes, they are listed 1 through 5, and I think they try to go a little bit intentionally from a little less personal to a little more personal, so that people can maybe become a little more comfortable in the conversation as it goes. And of course, if it's with a group that you've been working with for three weeks, or you've been working with a group for 3 days, the experience is going to be very different. And so hopefully the questions give a little bit of flexibility for people to kind of tailor to maybe their particular situation. Well, thank you all very much for your participation and for your comments in both the role play part as well as in the debriefing conversation. I want to just share a last few kind of recommendations and things that are suggestions, sometimes anecdotally, sometimes from the literature, to help offer support at your programs or the place that you teach or you work with learners. Some of these things are things such as memorial services for patients. My medical school anatomy lab had a memorial service for all of the patients whose bodies were donated for us to use as our cadavers during our first year. And that was a really amazing time to be able to see the family members of the person whose body we had gotten to know so well through anatomy lab, and like hear who they were as a person. And so that was a really cool thing that happened for me at my medical school. Also, things just encouraging trainee self-reflection, whether that's all of the interns get a journal at the beginning of their year and say, hey, if you need to write down something, here's your journal that we want to take, encourage you to take some time to do that. Making sure that folks have access to counseling, that they know about the employee assistance program, that if your program's in a position to offer, other counseling or therapy sessions for people if they need to, maybe ballot groups or whatever sort of reflection time that your residency maybe already has built in, making sure that, something like talking about patient death can be part of that. And then just modeling and mentorship. Being comfortable enough in your own self as a leader, as a teacher, to be able to let your learners know that, hey, I have feelings too, and it's okay to have them and be a great doctor. You don't have to be one or the other. It's in fact probably better to be both. So just kind of wrapping up, these were our objectives for today. The main one being practice debriefing using the Patient Death Debriefing System, a session, and just want to make sure that I really acknowledge Dr. Eng, who has very graciously let me present this material, as well as Gretchen Shaleski, who is my program director at St. Margaret's and really helped us to create this presentation. So with that, here are my references, and I will conclude. Thank you all very much. I really appreciate you participating with me today.
Yeah, thank you so much, Dr. Burval. I think this is such a great topic to bring awareness to and just to talk about. And thank you so much.